wonderful guest this evening, Dr. Charles Radis. Dr. Radis completed his medical training on a public health service scholarship, after which he was obligated to spend some time in service to the National Health Service Corps at a medically underserved area. And he arranged to serve this time on Peaks Island, which is, I guess we have a map up, on Peaks Island, which is just northeast of Portland at the western end of Casco Bay. At the end of this time, and the challenges that he faced, or despite the challenges that he faced, instead of doing what I think most people would have done, which is get out of there as quickly as they could, he and his wife decided this would be a good place to settle down and start raising a family and practice. And so he made those arrangements and has written about those years in a couple of wonderful, wonderful books. While he was there as a primary care physician, he and later training in rheumatology, he managed to publish both for peer-reviewed journals as well as for the popular press. He's been recognized by the as Maine Physician of the Year. Has also been recognized as Teacher of the Year by the University of New England College of Osteopathic Medicine. Reading Dr. Radis's books are exhausting. He describes in great detail these days of running from patient to patient, one disaster or near disaster after another. And then at the end of the day, he has to run over to Portland perhaps and make rounds on his patients there. And he's doing all of this in a 16-foot boat. And for anyone who spent time in those waters, I guess Portland is 5 miles, 6 miles from Peaks Island, something like that.
It's like a 20-minute ferry ride.
Yeah. But if you've been there and you've been on that water, you know it can be incredibly turbulent, incredibly crowded. It can be foggy, it can be unpredictable. That's a long, long 5 miles. And this is his day. I find that reading his books is like reading the New England Journal of Medicine while you're playing a Bert and I record in the background. And I think clearly Dr. Radis brings this sort of humor to his job. He clearly has his razor sharp diagnostic skills. He has a great understanding of people, and this added to his profound medical knowledge make his books highly, highly entertaining. So without further ado, I'd like to introduce Dr. Charles Radis.
Hello, everyone. Thanks for coming out tonight. I know that in-person meetings like this have been rare in the last 3 years, and with some infections being on the rise, it was kind of a close call about having this, and ultimately, I'm really thrilled to be speaking in front of an audience again, and I look forward to giving you some insights into what it's been like living on Peaks Island and servicing other islands over the years before I transitioned into rheumatology. And I wanted to begin by elaborating just a little bit about the Casco Bay Islands. And up through the 60s and 70s and early 80s, these were some of the poorest neighborhoods in Portland. And when I say Portland, because Portland has city islands, Peaks, Cushing, Long, the Diamonds, Cliff Island. They're all part of the city of Portland, and they're serviced by different ferries going down the bay with different schedules. But this is on the right here. This is still our home. This is taken in 1986. My wife Sandy, who's here tonight, has been married 43 years now, and my daughter, our first daughter, Kate, was born in the mainland, and our second daughter, Molly, was born a few years later on the island and almost was born on the island. And not quite being born on the island, she was almost born on the ferry boat going into town. So Molly, is perhaps a little true Peaks Islander. And another point I'd make is that, this was our original truck when we moved to the island. And this also still holds true for Peaks Island, is that vehicles do not have to be past inspection. And so when a vehicle would pass its normal lifespan and it would get handed around on the mainland, eventually would go to the Elephant's Graveyard or the Casco Bay Islands. And this vehicle served us well for a few more years before it bit the dust. And our house in the background, we'd already cleared out a lot by this time in '86. But when we first bought it, you almost couldn't see the house from the road. It was so overgrown with bittersweet and alders and everything. So this is into year 1.5 or so of when we moved out to Peaks Island. So these were poor islands, and now that has gradually changed very much. I don't know if some of you been out to the Casco Bay Islands, quite a few, and they've gradually become gentrified like islands everywhere. And but in those days, Peaks had the name of called the Welfare Island, which was its nickname because it was the poorest neighborhood in Portland. When people couldn't afford housing in Portland, they often ended up going to Peaks, and they would find very affordable housing, if not well insulated, and they would have large families. Our school, which currently goes from kindergarten through 5th grade, at one point had several hundred students. By the time this daughter went to school, there was about 100. By the time the second daughter went, there was about 40, and we're kind of in the 20s to 30s now. So it's become harder for families to move out to Peaks Island, young families, for affordable housing. And the other point that I would make until I go on to the next slide, and I'm eventually going to give a reading from the book, if that's okay, and be glad to answer questions after a while. The other point would be that ultimately, the reason why I became interested in serving my National Health Service Corps scholarship payback was because in my little community hospital, we would have people from the islands come in by fireboat. That was the rescue boat. And inevitably, none of them had primary care physicians. There were no health centers that were active consistently on the islands. Peaks had some things going on off and on over the years, but it was very difficult for people to get health care on the islands. And they would come in just a mess or at death's door. And inevitably, they would like turn around. They almost never died. It was just like, we used to joke a little bit, the dark humor of residency, it's impossible to kill a Peaks Islander. But instead of, staying for 7 days of IV antibiotics, day 3, you'd go in on rounds, they'd be dressed to go, looking at their watch. The next ferry is at 10:15. I got to go. Well, all these push and pull of folks wanting to get back either to Peaks or their particular island. So eventually I became interested and kind of would visit the various islands to see if they were interested in applying to become a health manpower shortage area. That took a lot of meetings while I was a resident, and that stumbled along. I would say stumbled because I really learned early on, if you're on Long Island, you just talk about Long Island. You don't talk about Cliff, you don't talk about Peaks, because even though the islands are relatively close together, they're kind of like wary neighbors. If they have a lobster fishery, they're very territorial. And so I found that if I was going to promote the idea of this becoming a National Health Service Corps area, that I had to really sell those people on it. And ironically, when I finished my residency, it was during, this is dating me, during the Reagan years, the budget was cut for the National Health Service Corps. So they created what's called the private practice option, meaning you could fulfill your scholarship responsibilities, but it would be a private practice. And so I went out there with really out any financial support, and I was terrible business person. I mean, back then, most doctors were in private practice. They weren't employees. And so I, stumbled along all those years with a lot of miscues and a lot of folks, could never pay their bills. And so it was a really a different kind of practice in terms of not having things really set up. So let me give you an overview. It's great that some of you have been out to Peaks Island. And this is a photo of Casco Bay. And, like all bays in which people try to estimate how many islands are in the bay, it's anywhere from 150 to 450. And part of that is, how you define an island. If you build a bridge to it, is it still an island? If there's no vegetation on it, even though there's a ledge at high tide, you still call it an island. So there's there's roughly 200 islands, but the year-round islands would be Peaks, which is the closest to Portland, Long Island, Chesapeake Island, which is the biggest, and also has some ferry service from the mainland. And then the most remote island is Cliff Island, with only about 80 year-round people on it. Long had about 350, Peaks has about 800, and Chesapeake about 350. So these were small numbers that would burgeon, even though they were in general not well off. There were still summer people who had long-term homes, and so they would get very busy for about 3 or 4 months of the year. So we moved to Peaks, and my practice was, we have it a little later where I practice. My practice was clinic hours on Peaks, 2 or 3 days a week. I operated a new little clinic out of the public safety building on Chesapeake Island. And then the other islands I would do house calls on. And that was sometimes an adventure. I didn't grow up boating, and I sunk my first boat in a storm. And so Sandy was always a little skeptical about us having another boat after the first one sank. And so the police in Portland, I developed a nice relationship with them. They would bring me in the police boat out to the outer islands, which was a more substantial boat, and wait for me while I did a house call. And so I was able to go back and forth to the other islands through the help of the Portland Police Department. So that's kind of the background of how I ended up on the Casco Bay Islands. One last aside is that I grew up in New Jersey, but it was very kind of, when I tell people about it, they go, "Where were you in New Jersey?" Because there was a little trout stream in our town, a little swath of forest. I grew up with a bunch of guys who loved to hike and camp. So I had a very, outdoor experience growing up. And my wife Sandy grew up on a dairy farm in New Hampshire. And when it came time to kind of living a little off the grid or off the usual pathway, we both agreed that this would be a good place to try for a year or two. But this is now year 37. So we've been out there quite a while. So what I thought I would do is begin by reading about 10 minutes of a chapter of what it was like on some mornings practicing on the Peaks Island Health Center. And I'll give you a little heads up because it's more focused on mental health issues for this particular day. Yesterday, I spotted the season's first iridescent blue and gold crocus poking through a patch of snow on my walk to clinic. Today, there were 6 in a small clump with the flowers leaning toward the sun. Within a few days, a week at most, the petals would wilt and drop, and if the warming trend held, other spring flowers would pick up the pace: daffodils, coltsfoot, blue violet, wild geranium. But my favorite, the most difficult to spy before the ethereal half-inch white flowers disappeared, was gold thread. And it's not the flower alone that delights me, Just beneath the surface is a thread-like orange rhizome, the source of a bitter herbal remedy for cold sores and intestinal parasites. And though Peaks, stepping away from the story, has been settled for hundreds of years, and at certain times there have been dairy farms, it's almost all wooded now again. And with the interior meadows reclaimed by red spruce and white pine, gold thread is back, and more likely it never completely left. I arrived at the health center a few minutes early. Setting my green satchel and day pack on my desk, I thumbed through the charts Anne had pulled for the morning clinic. Today, not necessarily by design, was mental illness day at the health center. Some of my long-term patients had improved, either with medications alone or in combination with counseling. Others floundered under the influence of coexisting alcohol or drug addiction. They were self-medicating their post-traumatic stress disorder, or psychosis, or major depression in the most destructive way possible, entangling loved ones in a web of anger, neglect, and sometimes emotional and physical abuse. There were those on the day's schedule who would deny they had mental illness. These patients saw me for their diabetes, or irritable bowel syndrome, or headaches, or heart disease, but didn't recognize how their mental health affected their physical health. Or if they did, their emotional baggage, the burden of their sadness was so heavy, they lacked the tools to make major lifestyle changes. It was these particular visits that exhausted and frustrated me because all too often I felt like a garage mechanic on speed dial. Here's my body. I'll come back in half an hour and take the pill you recommend. These were the yes, but visits. If I recommended a therapist, the patient replied, yes, but I tried that once and it didn't work. If I recommended walking to reduce weight or help with anxiety, the patient would agree, yes, but I'm too exhausted, or my knees hurt, or I don't have time. In these patients, I often prescribed a boatload of medications in sequence with only minor benefit. Or as the Chinese proverb says, if we don't change the direction we're headed, we'll end up where we're going. My first patient was an overweight woman with diabetes and unacknowledged alcoholism. I knew this because most everyone on Peaks Island was aware of the heavy drinking. She lived alone and staggered into the library twice a week. On the way home, laden with books, she bought a quart of Johnny Walker and a quart of gin at Feeney's Market. This was her fourth visit to me, and she hid her sadness behind a quick wit. A few months ago, on the new patient questionnaire under alcohol use, she wrote, whatever. Today was the first time I was seeing her in the office after she had admitted to being deeply depressed, but didn't want to see a counselor, but was willing to start fluoxetine, which is Prozac. I had a vague sense that she was a suicide risk, even if she wouldn't admit whether the thought had ever crossed her mind. It's why I'd picked Prozac as an antidepressant. The drug is difficult to overdose on. On the other hand, combining it with alcohol could be problematic. Did the Prozac help, I asked? Well, to tell you the truth, I'm not really sure. Maybe I'm borderline upright. She stared out the window, following the flight of a crow as it harassed a blue jay. Have you been able to get out and walk? No, I forgot about that. It's all I can do to drag myself up and down the stairs. I feel like I have rocks in my pockets. After 15 minutes of trying to initiate a meaningful conversation, it was clear she didn't want to talk about why she was depressed. Mostly, it seemed she just wanted a pill to take the edge off. She had a dog, Lily, and we chatted about that. At the end of the visit, I walked her out to the checkout counter, and Anne made a follow-up appointment in 2 weeks. Back at my desk, as I closed her chart and placed it on the shelf, a letter drifted to the floor. It was from an out-of-state psychiatrist and written more than 25 years before, when the patient lived in the Midwest. The letter described the trauma that she and her three sisters experienced when their mother confronted a burglar and the intruder shot the mother dead in front of the children. The man was eventually caught and sentenced to life in prison. In an instant, my entire view of the patient was turned on its head. I reread the letter. How does one survive a trauma of that magnitude? How does one have the will to go on? Do I share the letter with her? I told myself that my mental illness caseload was no different from other rural physicians, but that wasn't necessarily true. Between the ferry, walking, busing, or driving to an appointment and timing the return ferry home, it was often a 4 to 5 hour round trip for my patients to see a counselor. When I described to a psychiatry friend the challenges I faced on the islands, he concluded that the more severe the psychiatric disorder, the less likely a patient would connect with a mental health professional in Portland. Congratulations, you are the de facto mental health worker, he told me. And that had been my experience. For now, prior to each visit, I tried to clear my head, rev up my empathy cap, and look for opportunities to make each patient's journey a little easier. Dan was my next patient. At 5'9", 120 pounds, he was chronically 30 or 40 pounds underweight. Although he had always suffered from nervousness, his life changed dramatically when he rear-ended a truck in Portland while nibbling on a sausage sandwich. His head struck the windshield and he fractured several ribs on the steering wheel, but it was the sausage sandwich that left the most indelible scars. When rescuers found Dan, he was frantically clawing at his partially blocked airway. The sausage was successfully removed, but the emotional trauma left him a psychological cripple. For 5 years, he had subsisted on liquid nutritional supplements, despite there being no physical reason why he couldn't chew and swallow whole food. His wife, a pleasant, ruddy-cheeked woman, brought him to appointments and sat in our visits. She was respectable and optimistic, steadfast in the belief that we were only one intervention away from restoring her husband to a more normal life. But nothing seemed to work. Last year, Dan was briefly admitted to the hospital when his weight dipped under 115 pounds, and he suffered a grand mal seizure from an electrolyte imbalance. Psychiatry and neurology consulted and prescribed a slew of medications, crushed and suspended in a milkshake, but there was no progress towards solving the underlying swallowing disorder. As I leafed through the chart, I reviewed the barium swallow study of the esophagus and the MRI scan of the head. Both were normal. At least we knew there wasn't an unusual stroke syndrome or esophageal disorder affecting his swallowing mechanism. I had an idea. Why don't we begin with a tiny crumb, I suggested. Dan and his wife considered this and agreed that it wouldn't hurt to try. I broke off a small piece of blueberry muffin his wife had brought at Lisa's coffee shop. Dan picked up the crumb off her palm with his free hand and eyed the morsel skeptically. He held it up to the light and turned it this way and that, as if he were solving a puzzle. Then he placed it in his mouth. His wife glowed. Now we're getting somewhere. Then Dan swallowed, or rather attempted to swallow. He gagged, his chin jutted forward as he made bobbing motions with his head. His eyes flared and blinked. After a few seconds, he retrieved the wet fragment and carefully divided it in half and returned it to his mouth. Tears rolled down his cheeks. More head bobbing and gagging. He spit the blueberry muffin into the sink. I'm so proud of you for trying, I said, and patted him on the shoulder. You'll do it. Maybe trying in front of us isn't the way to go. Pick out something you really like. What kind of food do you miss? Is there a food you can try at home? I like Pop-Tarts. Well then, tiny piece of Pop-Tart might be the ticket, I said, trying to sound upbeat. Maybe you can experiment, practice chewing. When you're ready, give it a try. I'd be scared to try it myself, he answered. What if I choked again and no one was around? His wife patted him on the thigh. The visit was essentially over. His failure to manage even a single crumb signaled the depth and complexity of his illness. The police called. This is a rotary phone. An elderly woman up one of the interior dirt roads needed to be transferred to Portland with shortness of breath and fever, but was not cooperating. She called the emergency number, but now refused to leave her home. They told me her name, and I understood why they were calling. The patient had schizophrenia. Ann whispered to me that my last two patients of the morning had canceled. I had about an hour before the next ferry. I told the police I'd be right over. As I filled a compartment of my green satchel with blood and urine specimens to drop off at the hospital, I mulled over the morning and decided it went as well as could be expected. Then I biked up the dirt road toward the center of the island and reviewed what little I knew about the woman. I'd seen Ruth briefly 2 years before for a visit soon after her discharge from P6, a locked mental health ward at Maine Medical Center. At the time, she was prescribed Thorazine, a powerful antipsychotic. I had no idea if she followed through with a psychiatrist in town, but I'm certain I never saw her again at the health center. Officers Mike and John met me outside the cottage. Mike in particular was on edge. She looks terrible. High fever, respiratory rate 30 per minute. The fireboat is sitting on the public safety float waiting. She definitely needs to come to town, but won't get on the stretcher. I see, I said, thinking, and you think I can convince her? But we proceeded. Took another look at the cottage. Several gray asbestos shingles lay scattered on the ground. Ripped tar paper and plywood peeked through the missing shingles. The chimney was tilted and moss grew on the sagging roof. A footpath lined with striking cream-colored daffodils led to the front door. Okay, here goes. I knocked lightly and announced that I was Dr. Radis. A gravelly voice barked from inside. Go away. I have pneumonia. You might catch a cold. That's very considerate of you, Ruth, I shouted. May I come in and visit? There was a brief silence. Then a pair of puffy eyes peered through a crack in the shade. Fortunately, Mike and John had by now moved the ambulance and were nowhere in sight. I smiled and waved politely before reaching into my green satchel and placed my stethoscope around my neck. The door creaked open, followed by the sound of shoes scurrying away. I cautiously stepped inside. My patient was in bed, a white sheet pulled over her head like a corpse. Empty packing boxes, candy wrappers, shopping bags, magazines, a large fishing net lay on the floor. On the bedstand was a loaf of bread and an empty, opaque orange pill container labeled Thorazine. The expiration date was 6 months before. I recognized the prescriber's name as a Portland psychiatrist. Hello? Thanks for letting me in. There was no answer from the corpse. I counted the rhythmic up and down movement of the sheet. At 30, her respiratory rate was nearly twice normal. Do you mind if I sit down and visit? You're not visiting. You want to take me to the hospital? Well, it's true. If someone is sick, sometimes the best place for them is the hospital. I answered, tapping my fingers on the bedstand. Ruth, can I get you a glass of water? I'll make you a cup of tea? Maybe a piece of bread? I took a closer look at the moldy bread. Maybe that's not such a good idea. No, now go away. I sat quietly for a moment, unsure how to proceed. Did you plant the daffodils outside? They're quite beautiful. Ruth slowly pulled back the sheet and swung a pair of heavy work boots over the side of the bed. She was wearing flannel pajamas with the cartoon image of a skunk adorning both the front and back, and at a glance, she clearly belonged in the hospital. Her eyes were glassy and moist, her color pasty and sallow. She coughed and brought up a rag to her mouth, capturing a large gob of greenish phlegm. Catching her breath, she seemed to relax. I like daffodils. Me too, I replied. They really brighten up your pathway. I dangled the stethoscope in her direction and asked, do you mind? May I take a listen to your lungs? In response, she half turned and I placed the stethoscope against her posterior chest wall. Moist crackles extended from her right mid-lung field up toward the shoulder. It's more than the cold, I said. You definitely have pneumonia. Well, I knew that. Well, I'm just saying, I agree with you. I need to pee. She lurched to her feet and sat heavily onto a bedside commode at the foot of the bed. The effort left her winded. I pressed my case. Now, I'd like to have officers Mike and John come inside and help you onto a stretcher so that we can get you to town on the fireboat. You'll feel better if we give you some oxygen. There was another long pause. Officer John, Ruth finally replied. He's very nice. He brought my dog Lisa home when she ran away. For the first time, I was aware that the mop of golden hair curled beside her pillow was a small dog. I scratched Lisa behind the ear, then cracked open the door and waved in the general direction of a flowering forsythia, where I knew Mike and Big John were hiding. Meeting them at the door, I explained that nothing personal, but it might be better if only John came in for the stretcher. John ducked under the doorway, pulling the stretcher behind. Hey, it's Lisa. He reached out a giant, beefy hand and patted the dog lightly on the head. We'll take good care of her while you're gone. You're a tall one, aren't you? Asked Ruth. Yes, people have noticed that, John answered. Here, up you go. We're going to take a little ride. You'll be home before we know it. So that was the end of my morning. And inevitably, people would often, what happened to Ruth. So that day, I went into Portland, did rounds, drove up to another Cousins Island, took another ferry to Chesapeake Island, was seeing patients, and the police called me. They'd successfully gotten Ruth onto the fireboat, into Portland, into the emergency room, and ultimately Ruth decided she didn't want to be admitted. And after a while, they brought her home. She was never admitted. And I saw her at home during her recovery, and she did recover. She got a nice dose of IV antibiotics in the ER. But that was synonymous with a number of experiences that quite frequently, people, even when quite sick, didn't want to be admitted. They didn't want to leave the island. And so that was a constant kind of push and pull about making deals, seeing people in their homes. So with that, I'd be glad to answer some questions, either if there's something online or if any of you have questions, be glad to answer them. Yes.
So, I mean, this sounds like a fantastic model of practicing medicine, the time that you, at least at that point in time, were able to take. And all I can think about is, the line item focus on medicine now and navigating insurance and all that. I just wonder, even 30 years ago, you still would have had to grapple, I would think, with insurance companies. How did you reconcile what sounds like an absolutely necessary amount of time just to transact these individual appointments with what expectations might have been from insurers and other stakeholders around your practice?
Right. So, like I said, I was a terrible business person. And luckily, my wife, Sandy, was a social worker. And eventually, She got out of social work and became a plumber electrician on Peaks Island. And for years, she balanced that with our 2 children. So in terms, and we always kind of lived below our means. And so in the end, I never felt the pressure that I had to make a certain amount. And I certainly knew that a lot of people couldn't afford to pay. And I had secretaries who were pretty good at billing. Out of that, I always really liked the idea of private practice, as difficult as it was. And eventually, when I went into rheumatology, I joined a private practice. And it wasn't until 6 years ago, when I went part-time, that I became an employee for the very first time in my life. And it's been very strange, having that kind of experience with billing and a little bit of pressure to see more patients and everything. But I have to say, in some ways, it's physicians' own fault for giving up their autonomy. There's lots of moaning and complaining about, I'm forced to do this, I'm forced to do that. But physicians have a lot more power than they realize. And really, I think if they don't do enough to change the system from within in general, lots of exceptions to that. But I'm not as, I just turned everything off, which is probably okay. But I find that the evolution of healthcare into a corporate thing is that most of us have bought into that as physicians and given up autonomy for maybe more reasonable hours. But anyway, thank you. Yes, and then Owen next. Yeah.
Sure, yeah. So if they couldn't pay their bills, did they ever offer, by themselves to barter services? In other words, can I give you a bushel of squash or something? Did they ever get to
Yes,
that point?
absolutely. That's very nice. And
Oh, yeah, come back to the podium because
Hello.
people can't see you. Yeah. I need to see you. Yeah.
thank you. Yes, the question was, was there bartering, and did we get lobster or fish from time to time? And we did. And I think since Sandy was in the trades, we also had a lot of help, because that picture of the house, it was never insulated, before we bought it. And so, we had a lot of renovations. And so people in the trades really helped us out as we were gradually bringing it up to speed. So yes, there was a lot of bartering. Not a lot, there was some bartering.
Oh, there's a question online.
Yeah, and then Owen, yeah.
So can you talk about your general practice versus rheumatology?
Sure. So rheumatology is a practice of immunologic diseases. A lot of them are arthritis, but in general, rheumatologists mostly see people with autoimmune diseases like lupus and rheumatoid arthritis and scleroderma. And I found that it was very appealing in that for a lot of the patients in rheumatology, you follow them for decades and decades. And sometimes that's the only problem they have. And so you follow them kind of as a primary care person for that disease. And so I found that very satisfying. So it wasn't as different as you might think. And so that's what I continue to do part-time now. And I continue, we living on Peaks, I've stayed involved with the health center. And so, I will do a house call from time to time on the island. And I did want to give a shout out about, an inaccuracy in the back of the book on island medicine, is that it just came out a few weeks ago, and on the back, that part really wasn't vetted through me, and it makes it sound like I'm still practicing primary care on Peaks Island, and I'm making 100 house calls a year, and that stopped a long time ago, actually in 91. So this was a period of our life from 85 to 91, and after we came back to rheumatology, we ended up kind of reinserting into the medical system on the islands, but not in the same way. Yes.
I just want the story about Ruth. What fascinated me the most about that was that you thought she was taken care of. You thought she was in the hospital. You had done your thing. You would go visit her and so forth. But her immediate care if something happened in the middle of the night, there was somebody there to take care of it. Then you find, oh no, she's right up the street from where you live. And that's such a different thing than what most physicians go through. It's just so fundamentally different. I just wonder, how did you cope with the complete lack of privacy and separation from your patients? You described going to the little shop there by the wharf, and you're rushing to catch the ferry, going to buy a snack. You have to talk to 3 patients while you're standing in line about their things. It's people don't go through that.
Yeah, well, first off, I had never been in practice before, so I didn't have anything to compare it to. And it was wearing. Eventually it reached a point where, I felt like I couldn't go into the grocery store. And so Sandy would often do the shopping. And that whole full-timeness of it, with nights and everything, it was wearing. And, we went to counseling and had to work through things, and it wasn't easy. And I felt very guilty, 2 young children, and they would often kind of see me coming down the walkway, late after they were supposed to be in bed. And in some ways, not because of the guilt, but because I really enjoyed telling stories, I got in the habit of, when I get home, I would tell them stories, and literally hundreds and hundreds of stories. They would all start the same way. And so I kind of had my family time in small doses during those years, but it was hard. It was hard. No way around it. Yeah.
Have your patients read your books?
Yeah. So
Did they see themselves or see?
Yeah. So thanks for bringing that up. There's a variety of ways I've told the stories. One is that some of the more memorable stories, I've changed the sex of the person. I've melded together a couple of people for the story. A few people, as I was putting this together, I asked them, and they wanted me to write as much as possible about them and use their name. And so some people love that. And so and I had one patient in particular that just really didn't want to be portrayed at all, and I tried to respect and they didn't want to read the book, because it was a very difficult time in their life. So there was, so far, it's been a couple of years. I haven't had much negative pushback, but at some point I probably will have someone who's angry.
Well, familiar with Susan.
Not yet. Hi.
Hi, how are you?
I'm good, thank you.
Awesome. I am bred, born, and raised in Maine. Now reside here in Salem. So I grew up in the part of the forest and in the medical nursing profession. And my first job was in a really teeny tiny hospital, our local community hospital, where everybody knows everybody. And then I would go home and they would say, oh, so-and-so's in the hospital. And I'd be like, oh, really? After I just gotten off shift. So, so I really like, I appreciate the island life and being in teeny tiny towns and where all that occurs. But my question is, did you keep journals to do your stories to help you to remember what you were writing? Was that just something of a dump of your day, so to speak, of just like writing it down and you go back and look at your notes 20 years ago and you're like, oh my God, I remember so much of these few words that I've written? And B, if you could do it all over again, would you?
So A is easy. Some of you may recognize the at-a-glance pocket calendar that was ubiquitous. People carry these around. And so I have them back to the early 1980s. And I would, shortly after having an unusual conversation or the highlights of something that happened, I would write it in here, and later would retrieve it. And people's dialogue sometimes is just very, they don't realize they're being funny, but I had a elderly woman who had so many medical problems that she couldn't have a hip or a knee replacement, just barely getting around, very hard to see her get around, and she had chronic kidney disease, just a lot of medicine she couldn't take. Finally, I said to her, I said, well, we could try a tiny dose of oxycodone. I could split it in half, and you could try it, and, it could affect your balance, be careful and everything. So she comes back a week later, and she's really happy. She says, that medicine you gave me, that oxycondom, it really protects me from pain. I go, okay, yeah, right. So people would say those kind of things from time to time, and I really enjoyed capturing dialogue. So I never kept a diary per se, like I woke up, it was 70 degrees, it was always about unusual incidents that happened. The second part, would I do it over again? Wow. I really, really enjoyed that practice. And if I could do it over again, it would be that I, in order to kind of carve out a little bit of living, I wouldn't have been seeing hospitalized patients. And I actually eventually I had to have a half a day, a couple times a week in town with a little office, because those practices, seem to automatically pay the bills. So if I could simplify it, I would definitely do it again. I liked that aspect of kind of an old-fashioned medical practice. So don't have any regrets about having had those experiences. So yeah. Yes.
What
And
a
then,
comment on Ruth and
yes.
that whole sense of community. When you read about her, in the fireman, John, I forget names all the time, but I think it was John was the fireman. When he came in, he knew Lisa the dog. In just listening to that, in my mind's eye, I see the whole thing happening and see what happens when people are recognized, when they're known, when the people around them acknowledge them. And then she goes to the hospital, she gets her however many doses of IV antibiotics, and goes home and gets better.
Yeah.
I'm an old psych nurse, and I worked for many years at McLean in a number of different units. And I watched people, when people are allowed, when people are acknowledged, when people are known, there's never just one prescription for how people get better, but community is, from my perspective, the most positive thing that brings healing to people.
Right. And Peaks was and still is a wonderful community,
And you stayed there, right? You're still there.
even with being very rough around the edges. Because my oldest daughter, people would romanticize, oh, you went to school on an island, and she would say, okay,
Listen up.
my 13-year-old friend got pregnant. The other one ended up having an admission, so it wasn't idyllic, and there were people with hard edges.
But that's no place.
Everywhere,
No
everywhere.
place.
That's right. And so, I do try to dispel, that it was this romantic kind of thing living on an island, just like in your small town. There's some bad things that are going on in the background sometimes, but the sense of community is really wonderful. And like we would have patients with early Alzheimer's, and it was always kind of like, well, she's wandering, but how far can she go? And so people would kind of, oh, Ruth, you haven't been over here in the last year or two. No, well, let me help you. You need to make a left here, and then, I'll bring you back toward the store. And, so there was a lot of very, people did look out for each other in terms of that, and continue to, which has really been a great place to live. Yes.
Someone online wants to know, did you find a successor to your general practice, and how long did he or she last?
Right, so I've stayed on the Peaks Island Health Center board. And that picture I had of the building behind me was donated by a family. And eventually we, about 8 or 10 years ago, had a nice facility built in the middle of the island. Before that, though, we've probably had 6 or 7 practitioners come out for a year or 2 or 3. And our most recent practitioner is a nurse practitioner who's been there 6 years now. And it, I think it suits her really well. And she's an employee of Maine Health. And so she, it doesn't matter that, it underperforms, I guess, the way some clinics are. So we're really happy that she's been there, but there's really, and we went a good year and a half without a practitioner, and people really realized 800 year-round people and 2,000 or 3,000 in the summer, not having on-island care is really really tough on a community. And I go to some of the meetings. There's 14 year-round islands off the coast of Maine, and they get together through the Island Institute from time to time. And that definition of year-round island, the 14, is that you have to have a school to be a year-round island, a true year-round island. And oh my gosh, the things, people will talk about how hard it is for people to get any kind of medical care except in emergencies, up the coast, Penobscot Bay, some of the year-round islands. And when people visit, they don't realize if something really happens, there's not much to do on island. You can call in a helicopter, which don't fly always on bad weather. Boats take an hour and a half to get to Monhegan. It's still very difficult for people to get good medical care on their particular island. So Peaks has been really fortunate. We've gotten a lot of community support over the years for that. Yeah. Yes.
Can you tell us a little more about Peaks now, Peaks Island? Has it become gentrified? People snapping up parcels right on the water. So has the character really changed?
Yes, so it's definitely been gentrified, and it's been going on for a good 15 years or so. Not that many years ago, we had our first tear down, which was like, whoa, what are they doing? It's a perfectly good house and it's being torn down. So, and I know that's, happened all over years before that. Our perception of it is that a lot of our friends who've been there, and maybe their relatives before them, they're all still there in the background. So even though things have changed, kind of the background people that we're friends with are still similar. And actually, a fair number of the newcomers are very nice. They pitch in, and some aren't. But like that's true about some of the people who've been there forever. So there's a certain inevitability about it. But the part that's really that I feel terrible about is that affordability for young people to have a family and for them to go to school, has just been lost. And we have an organization that's trying to build affordable housing, and but it's catch up. You've kind of lost that opportunity, and there's lots of discussion about it, but very little can be done to reverse any of that. Okay, I'd be glad to stick around for a bit if people have other questions, and I think we do have some books for sale if people would like to buy a book, or I'd be glad to sign it. You can find the book or the previous book, which is Go by Boat, which came out a year before, most anywhere. And I believe the bookstore here in Salem carries it, but at least they used to. So if not now, you can certainly pick up a copy at any time. So I really appreciate the opportunity to come here. It's really nice to see so many people live, and thank you for coming out.